Now we're going to study ophthalmology. So basically we have three books for it. So comparatively we'll study from each of them. First one is AK Khurana. The next comes is your Nima. Okay. So HV Nima and Nathan Nima, and last but not the least, the Pass. Okay. So Parsons. And we have the comparative notes for the ophthalmology also, previous and the new notes for the ophthalmology. So the data, the content, everything in these three books is same, just they have shuffled all the things. Like in Qurana, the anatomy is given first. In parts, the development is given first, embryological development, as simple. So we will have a study pattern with AK Qurana only. Okay, so anatomy of the eye we are going to discuss first. So basically, what is the introduction towards the eye? So we are going to discuss the shape and the volume of the eyeball and what is the orbit. Okay. So what is the shape of the eyeball? It is aspherical shape, very important, or you can say it as a oblate shape or oblate spheroid. This is the shape of the eyeball. Then comes the volume of the eyeball. It is 6 ml, obviously, and the volume of the orbit would be more than the volume of the eyeball, because the eyeball is itself located inside the orbit, so the volume would be more of orbit, so it is 30 ml. So volume of eyeball 6 ml, volume of orbit 30 ml, very simple. So here they have told us that the shape of the eyeball is not spherical, okay, but it is oblate spherical, as we saw. Okay, then the next we have the poles. So the central point is maximally convex. Okay, so the maximum convexity is present at the central point. Okay, and what is convexity? So it is basically this type of structure. So this would be the outer one. Okay, so basically the central point is like this, and then they are telling like anterior and the posterior curvature of the eyeball is called as anterior and posterior pole, very simple. Okay, then comes the equator of the eyeball. So the equator of the eyeball lies in the middle, because equator, see the earth, so the equator is lying in the middle of the earth, at the middle plane of the earth. So same for the eyeball also, it would be lying at the middle plane between the two poles. Okay, the upper and the lower one, or in the eye, what poles we studied, this and this. Okay, so anterior and the posterior one and the central one. The next comes is the diameter of the adult eyeball. Okay, so anterior posterior diameter of the adult eyeball is 24 mm. The horizontal diameter is 23 mm. Vertical diameter is 23 mm again, and the circumference is 75 mm. Okay, the volume of the eyeball, as we studied, it is 6 ml or 6.5 slightly. The weight of the adult eyeball is 7 gram. Okay, important one. Okay, now the next comes is, so basically what are the coats of eyeballs, what are the layer covering the eyeball, very important. So the first one is fibrous layer, or you can call it as an outer core. Okay, then comes the middle layer, or you can call as the vascular core. The name itself suggests us fibrous, it is a protective one. Vascular, it is having blood vessels inside them, and the inner one is having nervous coat, have the nervous sensations, very simple. So beginning up, the first one which comes is fibrous coat. The fibrous coat is a dense strong wall, okay, and it is a protective wall for the eye. Okay, so intraocular contents, the contents which are present inside the eye, are protected by this fibrous coat, very simple. Now anterior 1/6, of the fibrous coat is transparent, and due to which we are calling it as cornea. Okay, so the anterior 1/6 of the eye is nothing but transparent cornea. Okay, it is cornea. Now the posterior 5/6 is opaque. It is opaque, and this is nothing but this is the sclera part. Okay, now there is a junction. There is a junction between the cornea and the sclera, and this is like a watch glass, and this junction is known as limbus. So the junction where the cornea and the sclera meets is limbus. Okay, now there is something called as conjunctiva, and this conjunctiva, it is firmly attached at the limbus. Okay, let's see a diagram. See the diagram over here. This is the eye. Here you can see the outermost layer, cornea. Okay, first we studied. Then comes the conjunctiva. Okay, this one, and the junction, that is called as Clemens canal. Okay, then the next comes is, then the outermost comes is sclera. Okay, then choroid, then retina. So these are the layers basically. Okay, we all have studied in our lower classes. Now the next part comes the vascular coat or uveal tissues. Now what is this? This is the part which supplies nutritional to various structures of the eyeball. Very important. And what all are these? These are from the anterior to posterior. These are iris, ciliary body, and choroid. Now the last but not the least, nervous coat or called as the retina. Okay, this is, it is considered, or it has been concerned with the visual function and projects the visual cortex through the visual pathway. So ultimately, what is retina going to provide you? It is vision. Okay, very simple. So what are the structures of the eyeball? The eyeball is firstly made up of three layers: outer, middle, and inner, as we studied. The outer layer consists of cornea, which is transparent, sclera, which is the white part of your eye, and the limbus, it is the junction of this cornea and sclera, as we studied. The middle layer, it is also known as uvea, and it is made up of iris, ciliary body, and choroid, as we studied. And the inner layer, which is made up of the retina. Very simple, students. Now coming up to the first one, that is cornea. Okay, the blood supply to the cornea, it is a avascular layer. It doesn't have any blood supply. The nervous supply to the cornea, yes, there is a nervous supply, that is trigeminal nerve or fifth cranial nerve. Very important. The ophthalmic nerve, which is the sixth one, it has three branches. Okay, three branches. Which? So lacrimal, frontal, and nasociliary. So nasociliary is going to supply the cornea. Very, very important, students. Okay, nasociliary of the ophthalmic nerve. The branch of ophthalmic nerve which supplies to the cornea is nasociliary. So basically we have a test to identify the sensations or the sensitivity of the cornea, and that is called as corneal blink reflex, and this is done by the help of a cotton wisp. So basically you are going to have a cotton, and you will be rubbing that cotton on the corneal surface, and if there is any sensitivity, then, so this is all about the test. So what we are going to do in the cotton wisp test, that is, we are going to touch it on the surface of the cornea of the patient. Okay, if the patient blinks, then the corneal sensitivity is normal. If the patient doesn't blinks after the touching of the cotton wisp, then the corneal sensitivity is absent or reduced, or it is negligible, and this is called as corneal anesthesia. This is called as corneal anesthesia. Okay, now what are the causes of corneal anesthesia? We have a mnemonic over here, that is HDL acts. HDL acts. What is this HDL acts? So H for herpes virus, D for diabetes, leprosy. Then comes the acoustic neuroma, and then due to any contact lens which is applied on the eyeball, due to which there is no sensitivity. So it could be due to any contact lens. It could be due to excessive usage of topical timolol. You have studied this on the pharmacology. It is a beta blocker, and due to this also the side effects tells us about the corneal anesthesia. Another comes a surgical trauma. So these were the causes of corneal anesthesia. Now there is something that is corneal blink reflex. This corneal blink reflex, it comes due to a sensory and a motor stimulation. The sensory is a afferent pathway and the efferent pathway is nothing but the motor, and the sensory area and the sensory signals are received by the fifth cranial lobe, as we studied. The motor sensations are received by the seventh cranial nerve of orbicularis oculi. Very simple. Now what is the clinical correlation? That is the Bell's palsy. It is characterized by the orbicularis oculi palsy. Okay, so basically orbicularis oculi palsy is seen in the Bell's palsy, and it leads to inability to blink your eye. Okay, so the patient would be unable to blink his eye. Okay, and this is called as legophthalmos. Legophthalmos clinical condition. Now coming up to the segments and the chambers of the eyeball, there are two segments of the eyeball, and these are anterior segment and the posterior segment. Very easy. Now the anterior segment, it has the crystalline lens, okay, and which are suspended from the ciliary body. So this crystalline lens would be suspended by the ciliary body. Okay, and other substances, that are other structures, these are anterior to it, anterior to the lens, there is iris, cornea, as we studied, and there is two aqueous humor filled spaces. Very important. And aqueous, the name itself tells us that this is nothing but water or water like fluid, and the humor filled spaces, the aqueous humor filled spaces, are anterior and the posterior chamber. Okay, so the anterior chamber first, it is bounded anteriorly by the cornea. Okay, basically, and posteriorly it is bounded by the anterior surface of the iris, anterior surface of the iris, and some part of the ciliary body. So this was anatomy. Then coming up to the anterior chamber is about 2.5 millimeter deep, 2.5 millimeter deep in normal adult. Okay, and it consists of 0.25 ml of the aqueous humor. 0.25 ml aqueous humor is filled inside the anterior chamber. Okay, now it communicates with the posterior chamber through the pupil. So the anterior chamber communicates with the posterior chamber by the help of pupil. This could be an MCQ. Coming up to the posterior chamber. So the posterior chamber, it is a triangular shape. It has a shape, it has a triangular shape, and it consists of 0.06 ml. The anterior was consisting of 0.25. It has 0.06 ml of aqueous humor filled inside it. Okay. Now coming up to the boundaries. Anteriorly, the posterior chamber has the posterior surface of the iris and some part of the cilia. Okay. Same. So the posterior wall of anterior chamber is made by the anterior wall of posterior chamber. Okay, very simple. Then posteriorly by the crystalline lens. So the posterior wall of the posterior chamber is made by the crystalline lens, and zonules, and laterally it is bounded by ciliary body. Very easy. So just now we saw the anterior segment. Okay, anterior segment in which there were two chambers, anterior chamber and the posterior chamber. Now we are going to the posterior segment. Okay, so talking about posterior segment, the posterior segment, it includes the lens, the vitreous humor, which is a gel like material, okay, filled which fills the space behind the lens. Okay, so this gel like material is filling the space behind the lens, and this is known as nothing but vitreous humor. The posterior segment consists of retina, choroid, and the optic disc. Very simple. So let's see the diagram. Okay, so the layers of the cornea. So basically we are here to see the diagram of the eye first, then we'll go to cornea. So what are the layer? First was limbus. These are the layer of cornea. So basically we'll discuss iris first. Iris, as we studied, sclera. Posteriorly you can see retina and optic nerve. Okay, and these are the two chambers. Okay, the anterior and the posterior chamber. Okay, and here this space, this hole is nothing but your pupil. Okay, this is iris as we discussed, this is sclera, the outermost one. So these are the two chambers. Okay, moving on to the visual pathway. Okay, so the visual pathway, there is a area inside the brain. So basically our eyes are the cameras. Okay, our eyes are the cameras, and they give sensations to the brain. Which part of the brain? The occipital cortex. This is the occipital cortex of the brain. Now what is the pathway? So basically this is the eye. From the retina there are optical nerves emerging out from the eye. From optical nerves, the sensations would be traveling to the optical chiasma, to the optical tract, and coming to the lateral genicular bodies. There, they are going to convert into optical radiations. These radiations that you can see over here, these radiations. And ultimately, these radiations are going to be virtual cortex. These will be going to the visual cortex. Okay, and this visual cortex is present in the brain in the occipital cortex. Very simple. So the next comes is the layer of cornea, or the outermost layers. So what are the layers of cornea? Let us discuss. So basically the outermost or the anterior layer is epithelium in nature. The next is non-keratinized. The layer is non-keratinized. It is stratified, and three categories in stratified. It could be superficial, or it could be squamous. Superficial layer, the middle layer, the basal layer is columnar. Okay, and only the basal cell layers can undergo mitosis and replicate and regenerate. So MCQ over here, which layer of cornea has the ability to regenerate? Okay, that is basal layer. It has columnar cells. Okay, the next comes is squamous. Okay, so non-keratinized, stratified and squamous. So diagrammatically you can see over here, here is the limbus where both the cornea and the sclera meets. This is the limbus. The layers of the cornea, these are posteriorly, this one, this is the posterior layer, and anteriorly this anterior layer or the outermost layer. Okay, and as we discussed, so basically the first layer is the epithelium and it has the sublayers non-keratinized, stratified and the squamous layer. Okay, then comes the second layer, that is Bowman's layer. Okay, Bowman's layer, it is not a true basement membrane. Okay, we expect a basement membrane down the epithelium, okay, as we see in the blood vessels. So but here there is no true basement membrane, so Bowman's layer is not a true basement membrane and this could be an MCQ. Okay, now it is pass negative, does not stain with periodic acidic skiff reagent, as it is not a true basement membrane, and it is not a true basement membrane, it is a false basement membrane. It is acellular, and that's why it does not regenerate. Very important. The next comes is, if it does not regenerate, then any damage to the acellular layer or the Bowman's layer can lead to scar formation, and this scar would lead to corneal opacity. Very simple. So this is the reason, so that patient could suffer from the loss of vision due to formation of this scar. Very easy. Now moving on to the type of corneal opacities. What are the types of corneal opacities? The first type, it is nebular, then macular, and the last comes is leucomatous. First one, the nebular, there is a faint vision. Okay, so basically there is a faint vision, not completely whiteness has gone due to scar, there is a faint vision. Okay, the complete white scarring is seen in leucomatous type. Okay, so leucomatous type of corneal opacity, you can see complete vision is lost. Okay, complete pupil margins have been gone. Then comes your nebula. In this, vision is there, the pupillary margins are also there, and the macular type, there is vision but there is no vision, of the structures of iris, and the papillary margins are visible. So here we have a diagrammatic image of nebula. This is the light source and it can easily pass through the cornea and differentiate. Okay, but in leucomatous, the light source cannot easily pass through or cannot even pass through. This is leukoplasia, not visible. So a very important point over here, in the types of corneal opacity, the maximum visual disturbance or distortion is caused by which type? So it is nebular. Why nebular? Why not leucomatous? Because in nebular the light rays get diffracted, due to which there will be multiple imaging at the retina, and this will cause disturbance and distortion. Okay, and that is why nebular causes the maximum visual disturbance. Now moving on to the third layer of the cornea, that is dual layer. Okay, stroma and the descending membrane one. Okay, so basically the first, the stroma. The stroma, it makes up the 90% of the total corneal thickness. Very important layer. And that is why the most common type of collagen, type 1 collagen, is seen over here. Okay, the most common type of glycosaminoglycans over here are keratin sulfate. Very important. Now the next layer comes the dual layer. The dual layer is the strongest corneal layer again. Okay, and it is the thickest, ranging up to 7 to 14 microns. Okay, thickest. Now another comes is the discriminant membrane. This is, it is secreted continuously by the underlying epithelial cell. So it is secreted continuously the epithelial cells are producing this, and it can regenerate. So it can regenerate, and the thickness increases throughout the life. The thickness is increasing throughout the life. This can be an MCQ. Now another point, peripheral termination of the descemet membrane is known as Schwab's line. Very important. The peripheral termination of discriminant membrane is known as Schwab's line. Now comes the layer of the cornea, the innermost and the posterior layer. So we studied the innermost layer is formed by the endothelium. Then single cell layers are over there, and it is metabolically active layer. Okay, it helps in maintaining the corneal transparency. How? So by active sodium potassium ATPase pump, it maintains the corneal dehydration. Okay, so it prevents from corneal dehydration by the active sodium potassium ATPase pump. Now tight junctions are present in between the adjacent endothelial cells. So in between the endothelial cells or the endothelium, there are tight junctions. Very easy. So what are basically endothelial cells? So basically endothelial cells are in number approximately 2400 to 3000 cells per millimeter square. Okay, then so there is an adaptation mechanism known as polymegates and polymorphism. So polymegathism and polymorphism, these are the two adaptive mechanism. Note, these are the adaptive mechanism. And when the endothelial cells are in number less than 2400, but there are more than 500 cells per millimeter square, when this is the condition in the cornea, then there would be this adaptive mechanism. Okay, now if if the number of endothelial cell decreases from 500 millimeter square, then it will lead to corneal decompensation. Okay, corneal decompensation. The next point is, so how we will count this endothelium? This is done by the specular microscopy. Very important, students. Okay, So that was all about the cornea. Now in the next lecture we are going to study about sclera.